Our next presenter is Dr. Andrea Cheng Hakimian, and Dr. Cheng Hakimian is a board-certified neurologist at University of Washington Medical Center and Harborview, and a UW Assistant Professor of Neurology. She provides care to patients with epilepsy, including women with epilepsy during their pregnancies. She enjoys getting to know patients and educating and empowering them to participate fully in their care. Dr. Cheng Hakimian earned her MD from Washington University in St. Louis. She is board certified in both neurophysiology and neurology. Her clinical interests include women's health and epilepsy. Her research focuses on women's health and epilepsy with special emphasis on pregnancy and epilepsy. Please welcome Dr. Cheng Hakimian.
Hi, everyone. Thank you so much for coming today, especially those of you who've come from afar, and a special hello to all the familiar faces out there in the audience. So I'm going to be talking today about women's health and epilepsy. This was a topic that came kind of naturally to me when I finished training. I was one of few female epileptologists in my state, and so I came to know this topic sort of naturally. I have no disclosures, and as you can imagine, when we talk about women's health and epilepsy, a lot of what I'm going to talk about is regarding pregnancy, and especially the concern for birth defects of seizure medications during pregnancy. But I'm also going to talk a little bit about contraception and about issues around the menopause. So I know we all just had lunch, and I want to keep this talk to an interactive one. I would like to see what the audience's guess is on this. What do you think is the unplanned pregnancy rate among women with epilepsy? Is there anyone for 10%? 20%? 40%? I see a few 40s. Yeah, awesome. 60%? 80%? Oh, wow, okay. All right, well, I think this audience perhaps knew more than I did when I was going into this field. The unplanned pregnancy rate in this population is 50%. So approximately half of babies born to this population are unplanned. And I don't need to tell anyone that is atrocious, and we as physicians, we as society need to do better. So for women with epilepsy, they have a special need for planned birth, for planned pregnancies, because as I referred to earlier, seizure medications are associated with elevated risk of birth defects. And to make things even more complicated, many seizure medications decrease the effectiveness of birth control methods. And on top of that, many birth control methods decrease the effectiveness of seizure medications. So they come into this situation with kind of a double whammy. So I'm going to do another poll of this audience. I'm going to say a list of birth control methods. Would you please raise your hand if you think that this type of birth control is effective for women who are taking seizure medications? Okay, so you can raise your hand for one or for as many as you want. Who thinks that the pill, or more formally known as the combined oral contraceptive pill, is effective for women who take seizure medications during pregnancy? No takers. Okay, awesome. How about the NuvaRing or the vaginal ring? Okay, some takers back there. Awesome. How about Depo-Provera or the shot? A few takers there. Awesome. The IUD? Oh, yeah. A big show of hands. Okay, this audience knows what it's doing. Nexplanon or Implanon, okay, some hands there, and the patch, or more formally known as the combined contraceptive patch, a few takers there. Okay, awesome. So I'm going to first start off with what kinds of contraception are the most effective among the general population, and this is a slide from the CDC. At the bottom level, the bottom tier of this slide, are the least effective methods of contraception. So this would result in about 1 in 5 pregnancies per woman per year, for each woman in a year. No, per 100 women in a year, sorry. So this would include your barrier methods such as condoms, withdrawal method, fertility-based awareness methods, and spermicide. And then above that is what I would consider the good enough efficacy contraceptive methods like the pill, NuvaRing, diaphragm, Depo-Provera. And then the top tier are the super effective contraceptive methods such as sterilization and the IUD. So let's talk about the concerns for women taking seizure medications. So there is a whole list of seizure medications that not only interact with hormonal birth control, but are interacted by hormonal birth control. And some of you may have heard the term enzyme-inducing antiepileptic drugs, but another way of thinking about that is that the older generation of seizure medications are most often the ones that have this complication. So phenytoin, phenobarbital, primidone, carbamazepine, and then among the newer medications, higher doses of topiramate or oxcarbazepine. And then there is the special beast that is lamotrigine that we'll talk about in another slide in just a little bit. Luckily, there are medications that are not affected by hormonal birth control and are that don't have any of those bidirectional interactions, and that includes levetiracetam, lacosamide, valproate, gabapentin, zonisamide, and low doses of topiramate and oxcarbazepine and pregabalin. So I mentioned that lamotrigine is kind of its own beast, and that is because it has is a strong interaction one way and a weak interaction the other way. So the strong interaction is that hormonal birth control, especially the estrogen component of it, strongly reduces the serum levels, the blood levels of lamotrigine. So if a woman were on lamotrigine were to start taking birth control, she could be expected to have a 50% reduction on average in her serum level just because of that drug interaction. This causes issues, of course, when she thinks about contraception, but we'll talk about that equally later when she thinks about pregnancy. On the other side, lamotrigine is known to reduce the progesterone component of the combined oral contraceptive pill. However, there's no evidence yet in the small studies that we have done that the small reduction in the progesterone component has led to breakthrough ovulation. So there is most likely a possibility that in sort of borderline cases when ovulation is barely being suppressed by a low-dose hormonal contraceptive, that the addition of lamotrigine may make that ineffective. Concern to be thinking about. So with that, I think we can go back to our CDC chart and cross out some methods of contraception that are unlikely to be reliable for women taking seizure medications. And that would include hormonal methods that give you low doses of hormones over time, such as the implant, Nexplanon, Implanon, or the contraceptive patch. However, there are many methods that are still very effective, and as you all seem to already know, the IUD is very, very effective still. It doesn't matter if it's the Mirena IUD or the copper-based IUD, Paragard. The Mirena IUD releases hormones, but the hormones are effective locally. The contraception comes from the local action in the uterus and not from the bloodstream effects. So any interaction with lamotrigine or any of the other seizure medications do not affect its efficacy. If for some reason a patient of mine doesn't want to have the IUD or does not want to use hormones at all, I will advise her to use combination of both a male condom and spermicide with every act of intercourse, which will then bring up the efficacy to this sort of good enough tier of effectiveness. So I'm impressed that everyone here raised their hands pretty much for the IUD, and I feel like this population and their friends and family will not be part of that 50% that I talked about at the beginning. All right. Do we take questions at the end or with the discussion? At the end. Okay. All right. So I'm going to go on to pregnancy, and this is a picture of my 19-year-old baby. She looks different now. So I'm going to first talk about birth defects, because that's what everybody is thinking as soon as they come to my door and tell me that I'm pregnant. Our information about the effect of seizure medications on birth defects necessarily comes from observational data, because it would be unethical to take a group of pregnant women and say, hey, I'm going to randomly make you take seizure medications that I think may be toxic for your baby, right? So we have to just observe what happens when women who have to take seizure medications anyway and follow them out over time. And the studies that do this are called the registries. We have a registry here in the United States that's called the North American Anti-Epileptic Drug Pregnancy Registry. The data for this I'm going to show you, but is also online, and here's a URL if you ever want it. When I counsel my patients about pregnancy, I literally pull up this page and we talk about the data. But there's also many international registries all across the world, and another prospective trial that we're going to talk about that really looks at cognitive and behavioral development called the NEED study. We'll talk about that in detail later as well. So this is the data from the North American Anti-Epileptic Drug Pregnancy Registry. And the first thing I want you to direct your attention to is this external control group. This is a group of healthy American women who are not taking seizure medications. There's about 70,000 of them that have been followed up since the late 1990s. And their chances of having a baby with a major birth defect is around 2%. And that's consistent with what we found across time and across the world as far as what is the rate of birth defect in a healthy population. So that 2 to 3%, it represents the absolute floor for how low we can realistically expect birth defect rates to go. Okay, so with that in mind, I want to draw your attention to the lamotrigine data. This is a group of about 2,000 pregnancies where mom takes lamotrigine starting from the first trimester onwards. And that group, their children have about a 2% risk as well of having a baby with a major birth defect. In other words, not significantly elevated above the normal healthy control population. Another one that's turning out to look really good is levetiracetam. There's been about 1,000 women who have been followed who have taken this medication throughout their pregnancies, and they also seem to hold about a 2% risk. On the other end of the spectrum, valproic acid or valproate, there has been about 350 women followed, and their chances of having a baby with a major birth defect is 8%. And that is statistically significant in this registry, and I will show you later that the elevated risk of valproate is replicated across all the registries across the world. In the North American registry alone so far, phenobarbital is also associated with a statistically elevated risk of birth defects at 6%. but this has at least not yet been duplicated across the other registries. So I think everyone looks at phenobarbital with a little bit of a question mark, but it is not yet known to be a bad player. So here in this slide, I've tried to give you a sort of a more pictorial summary of the major registries across the world. The color coding of the bars, this sort of teal green is carbamazepine. The yellow is lamotrigine. This gray is no seizure medications at all. The forest green is phenobarbital, and this blue is valproic acid. And if you sort of defocus your eyes a little bit, or if those folks in the back of the audience have got it easy, what you see is that across all the registries, valproic acid shows an elevation of birth defect rate compared with no medications at all, whereas lamotrigine and perhaps even carbamazepine show no particular elevation. So most of us feel very comfortable with a woman approaching pregnancy who is taking lamotrigine or levetiracetam, and most of us become alarmed when a woman is contemplating pregnancy and is taking valproic acid. So those are the drugs to keep in mind from all the data that we have in so far. The registries I've talked about so far have really talked about medications taken singly, but many women need more than one seizure medication to control their seizures. So they have to take multiple medications during pregnancy. What happens to the birth defect rate with that? So this graphic I've organized slightly differently. Now the colors are organized by the study. So this teal is the lamotrigine registry. The yellow is the UK registry. The red is international registry called EURAP. And the purple is a Scandinavian registry. And what you see is a pattern where with polytherapy, so here, 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 and here, the risk goes up. The lamotrigine registry actually tells us some interesting data, and I include this registry even though it is industry funded, because most of us feel it was very well done and without bias, and also because it gave us some useful information. So what the lamotrigine registry did was to separate women who take more than one seizure medication into groups who did or did not have valproic acid in their combination. So this bar is lamotrigine plus any medication other than valproic acid, and this bar is lamotrigine plus valproic acid. So you see that the bulk of the elevation in risk of birth defects comes from valproic acid as well. So with that information, a lot of moms come to me and they say, well, so why can't I stop taking my seizure medications since I'm pregnant? After all, I've been seizure-free for many years now. Why can't I stop? And that's a very reasonable question to be thinking. The problem is that when those women stop seizure medications, they're at risk of having breakthrough seizures. And on a very prosaic level, if you have a seizure, you can't drive. And if you can't drive, you can't get to work. You may lose your job. Or if you have a seizure while you're at work, your work may decide that they need to let you go. So that often is not a possibility for women. And as well, if you just do a simple back of the envelope calculation, people who have uncontrolled seizures have a 1% mortality each person year, and 9 months of that is 9/12 of a year, which is a 0.75 mortality rate, or approximately 8 out of 1,000 women who are pregnant will die. I don't know if there's any OBs in the audience, but when I say this to the OBs I've talked to, they are horrified by this number. They often feel like, oh, wow, that's like in the days before antibiotics. This is not modern medicine anymore. This is an extremely elevated mortality rate. So, can't stop seizure medications because of that, but there's also the concern for status epilepticus, which is prolonged seizures that don't stop by themselves. Status epilepticus is a medical emergency. The heart, the lungs, the kidneys, the muscles can all go into failure with prolonged seizures. And in the old days, before 1980s, status epilepticus was associated with very high mortality for both mom and baby. So 30% for mom and 40% for baby. These days, I think we've gotten better at controlling status epilepticus. We have got a much bigger range of medications that we can treat it with. In one international study, they reported 36 cases of status epilepticus and only one miscarriage with no maternal deaths. But even in that better scenario, when you're in status epilepticus, you'll be receiving many, many medications at very high doses. And it is not at all clear that you would have been better off having that rather than having continued your one seizure medication throughout pregnancy. This is another slide that I like to show my moms when we talk about whether or not she should stop her seizure medications. So this study looked at 3 groups of women. One is about 45,000 women who are healthy and are not taking seizure medications. And then a group of women who have epilepsy, but they've had no seizures during their pregnancy, about 200 of those. And another 200 women who have epilepsy and did have seizures in their pregnancy. They followed these women out and took note of bad outcomes in the pregnancy. So that includes stillbirth, seizures when the child reaches 7 years of age, mental retardation in the child, and any bad outcome. And as you would expect, the healthy women did the best. But even among the women with epilepsy, if the woman had seizures during pregnancy, she was at elevated risk compared with women who didn't have seizures of all of these bad outcomes. So mom having seizures during pregnancy puts baby at risk of having epilepsy herself. So I won't go into this in too much detail, but we can all imagine another risk of having seizures during pregnancy is trauma. If you're going to have a seizure, you're going to fall, you can hit the abdomen, you can have a miscarriage as a result of the trauma, or go into this medical emergency where the uterus separates from the wall of the placenta, and there's increased risk of signs of fetal distress. So, birth defects, we know that they can happen, especially with certain seizure medications, but mom can't stop taking them. So what choices does mom have? Well, luckily, prenatal testing is quite good these days. As early as the first trimester, we can learn a lot of information from an amniocentesis or a chorionic villus sampling testing. Most of major malformations, major birth defects can be detected with this one test alone. And early in the second trimester, the combination of prenatal screening and an anatomical ultrasound will detect 90% plus of major malformations. So by early second trimester, mom can know and make a decision about what she wants to do. She can elect to terminate the pregnancy, or if she wishes to continue the pregnancy, she can line up the necessary medical team so that baby enters the world with as many chances as possible. We'll also talk a little bit about the use of folic acid or folate to reduce the chances of birth defect in a little bit as well. All right. So up until now, I've talked about the structural abnormalities that could result from exposure to seizure medications during pregnancy. Now I'm going to talk a little bit about the cognitive and behavioral issues that can arise from exposure to seizure medications during pregnancy. And this largely comes from a study called the NEED study, Neurodevelopmental Effects of Anti-Epileptic Drugs. This was an international study that started in the late 1990s and is still ongoing in another form called MONEED. But data has been reported out to when the children have been 6 years of age. So for quite a while, the children have been followed out. And at 6 years, there were about 250 children who were still being followed. They were exposed in the uterus to carbamazepine, lamotrigine, phenytoin, or valproate in monotherapy, just as an individual medication versus in combination. And these kids were tested for IQ and cognitive performance and all sorts of data taken about the pregnancies in these children. The results are here, and I know this is a little bit of a busy graph, but I'm going to try to break it down so that it's a little more digestible for us all. This graph is for the group that was exposed to carbamazepine. This is for lamotrigine. This is for phenytoin, and this is for valproic acid. The x-axis here is the dose of the medication, with this being a higher dose and this being a lower dose down here. And the y-axis is the IQ of the child at age 6. So up here, higher IQ, down here, lower IQ. And what you see for carbamazepine, lamotrigine, and phenytoin is that there is not a strong relationship between dose of the seizure medication and the IQ of the child. So another way of putting that is that there doesn't seem to be much of an effect of the seizure medication on the IQ of the child. Unfortunately, for valproate, for valproic acid, as the dose of valproic acid increases, the IQ of the child decreases. The authors of the NEED study also approached the data analysis in a slightly different way. And again, here, this is the carbamazepine group, this is the lamotrigine group, this is the phenytoin group, and this is the valproate group. And again, the y-axis is the IQ of the child at age 6. The x-axis, however, is the IQ of the mother. And as a little bit of a background, the strongest predictor by far of the IQ of a child is the IQ of the mother, to the extent that not only for this study, but for any cognitive research study or analysis, is almost impossible to interpret the IQ of a child without knowing the IQ of the mother. So mother's IQ strongly predicts child's IQ. And what you see with carbamazepine, lamotrigine, and phenytoin is that as mom's IQ goes up, child's IQ also goes up. Okay? But what you see with valproate is that that relationship is gone. Mother's IQ doesn't seem to hold any ability to predict what child's IQ is. So whatever protective benefit mother's IQ provides is demolished by the toxicity of valproic acid. So valproic acid, bad for structural abnormality and bad for cognitive outcome. All right. So I'm going to switch topics a little bit. I mentioned when we talked about contraception that lamotrigine is affected by estrogen, and that is true particularly in pregnancy when estrogen levels rise, and particularly in the second and third trimester. You will find that women will need higher doses of lamotrigine just to keep their blood levels the same. On average, a woman can expect to double the amount of lamotrigine she takes in by mouth by the end of her pregnancy just to keep the blood levels the same. Thankfully, lamotrigine is kind of the outlier in that. The other medication that we like to use during pregnancy, levetiracetam, also shows a drop from baseline to pregnancy, but not as dramatic a drop. And there's also a lot of variability from woman to woman. Some women see a big drop, some women don't show a drop at all. So what we all do for pregnant women who are taking seizure medications is we obtain baseline levels, ideally before pregnancy, and then we use that as a target to frequently check blood levels and then adjust the medication dose to duplicate the baseline seizure-free level. Now, when mom delivers, her body, at least as far as drug metabolism is concerned, returns to normal pretty quickly. And by 3 days postpartum, she's a good ways there. And by 3 to 4 weeks postpartum, she's pretty much all the way back to normal, at least as far as drug clearance is concerned. So what that means is that if mom continues to take double the pre-pregnancy dose of lamotrigine, say a month after she delivers, she's going to have way too much lamotrigine. She's going to feel toxic and she will not like you if you keep her on the same dose. So standard of care now is that either you frequently check blood levels or you presumptively drop the dose to the pre-pregnancy dose within the first month or weeks of postpartum. All right, changing topics again a little bit. I mentioned before that one of the ways we can reduce birth defects is by supplementation of folic acid, and that comes from the observation that certain seizure medications, particularly valproate and carbamazepine, are associated with spine and brain abnormalities such as spina bifida. And in studies that have looked in the general population, it seems that folic acid can help to prevent these defects. So again, standard of practice is now that when a woman comes in of fertile possibility, in a fertile age group, that she start on folate, and then she continues that until her fertility period has passed, until she's in the menopause. Okay. All right. So we've talked about a little bit about delivery. And one of the concerns that my patients pretty much always comes to me for is that she's concerned she'll have a seizure during delivery. We all know that stressful situations, such as delivering a baby, may put you at risk of seizures. But luckily, this doesn't happen all that often. In one of the international registries, and that, by the way, took in all comers, whether the moms were seizure-free at baseline or if they had uncontrolled seizures, the incidence of seizures during delivery was very low, at less than 5%. And so if a woman were to come in who had been long-term seizure-free and seizure-free during pregnancy, I would not be losing much sleep over her having a seizure during delivery. But even if she does, there are good medications that are easily available in any hospital situation to control the seizures. I don't generally advocate for a home delivery for women with epilepsy, but other than that, I think she will be just fine during delivery. All right, and I think this is a bit of information that hasn't quite reached the general consciousness, even in the neurology field, but I think is important to talk about. So everyone's concerned about seizures during pregnancy and during delivery, and that's very legitimate, and I'm glad that everyone has this addressed, but not everyone is aware that probably the highest risk time for having a breakthrough seizure is actually in the postpartum period. And for those of us who've been mothers, who've been new mothers, will easily understand that, well, you're very, very sleep deprived, right? And that in and of itself is a trigger for breakthrough seizures. But also your life is so busy, you may not even remember whether or not you have taken your seizure medications that day. And reflecting that, we find that the compared with control women with other diseases such as diabetes but not epilepsy, the risk of rehospitalization in the first 6 months postpartum is elevated. It's about double compared when comparing women with epilepsy, and the risk of death in the first 2 years postpartum is actually 6 times that of the control mothers. And from the data that we can find, this risk of death comes from breakthrough seizures. So now when I counsel my moms, I sit down with them and I make an explicit plan for how they're going to get 6 hours of uninterrupted sleep each night. So that means somebody else has to take care of 1 feeding per night. I have them identify that person and identify what feeding that's going to be done so that there's a plan in place for mom to get adequate sleep. I make sure they have a pill box, a Mediset, so that if they forget whether or not they took the medication that day, they can check, and also that they don't end up accidentally double dosing because they couldn't remember whether or not they took their medications. And that they have some sort of a reminder, such as a smartphone alert, so that even when life is otherwise too busy, they will be reminded that they need to take their seizure medications. All right. Breastfeeding is another topic that comes up. Again, this is not data that we can acquire by randomizing women to breastfeeding or not breastfeeding. So we follow these women who choose to breastfeed. And in the NEED study, about 40% of women chose to breastfeed, and they breastfeed for about an average of 7 months. And I don't know how well you can see the data here, but what the results were is that the children who were breastfed showed no cognitive decline compared with the children who were fed with formula. And in fact, if you look at the valproate group, the breastfed children had higher IQs, so the IQ was 106, compared with children who were fed with formula, whose IQ was 94 on average, and that this difference was statistically significant, although this is a subgroup analysis, and so it's not to be as firmly trusted. So what we take away from this is that there is no reason to discourage women from breastfeeding, even if they're taking seizure medications during breastfeeding. And that may even be particularly true with valproic acid. Okay, so a last thing that I tell my patients about, and this is all common sense once we think about it. So you want to make sure during the postpartum period, when you know you're already at higher risk of breakthrough seizures, that at any moment, if you should have a lapse of consciousness, that you are safe and the baby's safe. So if you feed the baby, if you change the baby, strap the baby onto the table so that if you lose consciousness, baby doesn't roll out and down on the floor. When you walk with the baby, either use a baby carrier or use a stroller, because again, you don't want baby to fall. If you fall, please do not hold the baby when you're ironing or cooking, because you don't want to drop the baby on a hot stove or on a hot iron. And don't bathe the baby by yourself. Babies are notorious for being able to drown in 2 inches of water. And if you should have a lapse of consciousness, you can't prevent that. Okay, I'm going to move on. I think I still have a few more minutes. Yes, I'm going to move on to postmenopause. And I'm going to first talk about seizure control around the menopause. A lot of women are concerned because they don't know how the menopause is going to affect their seizure frequency, especially if they had catamenial seizures previously where their seizures were tied to the menstrual cycle. So as there's nowhere near enough information in my mind about this. But the studies that are out there suggest that there may be an increase in seizures in the perimenopause, in the year or two before menopause, but then that seizures tend to decrease in the postmenopausal state. Hormone replacement therapy with both estrogen and progesterone doesn't seem to have much of an effect on seizure control around this time, but it's possible the supplementation with natural progesterone could be effective, and this is research that really needs to get done. All right, and then the other big issue around perimenopause is bone health. So you all may have heard of osteoporosis, and that's a condition where the bones weaken. In this graphic here is sort of like a microscope view of healthy bone, and this is a microscope view of osteoporotic bone. So what you see is that the walls of the bone have become fragile, and you can imagine if this bone were to take an impact that it might break easily. So there's definitely an increase in fractures among people taking seizure medications, particularly that older generation of seizure medications, the enzyme inducers. That is true even if you consider age and sex into the variable. And it doesn't seem to be just because of decreased bone marrow density. There seems to be subtle changes in the structure of the bone in animal studies that we haven't yet quite investigated in humans to verify. What seizure medications are most strongly associated with weak bones? It's usually the older generation of seizure medications, with perhaps carbamazepine being better among them. The newer seizure medications don't seem to have as strong evidence for weak bones associated with them. And so if a woman has been on one of the older seizure medications for more than 5 years, or if she has other risk factors like she's postmenopausal, she's of a race that is at elevated risk, if she has a family history, if she smokes tobacco or is small bone to begin with, then she needs to be referred for screening to see if she has weak bones. If she does, then I generally refer to an endocrinologist, but every woman should be getting adequate calcium and vitamin D. The calcium now, my understanding from the internal medicine world is that it should come from the diet and not from supplements to guard against heart disease. And women who are taking the older seizure medications may need to have higher doses of vitamin D. Other therapies such as hormonal therapy or the bisphosphonates may be needed as well. Okay, so I'm going to end my show, end my slideshow with this slide. This is a picture I took from the Wikipedia entry for women. And you can see that these are the women who are the movers and shakers of this world. You have Eva Peron, Marie Curie, Queen Elizabeth. Can anyone here point to the woman who we think had epilepsy? So Joan of Arc is here, and it's thought that her visions were possibly epileptic visions. Okay, thank you for coming today, for listening today.